This presentation is on pelvic supports for pubic joint dysfunction and for symphyseal diastasis. And a brief summary of what we will cover is we will cover placement of a pelvic support worn at the level of the pubic joint, which is also the level of the trochanters, as being superior for pubic joint dysfunction, and it is a standard of care in the acute management of symphyseal diastasis, which is rupture with separation of the pubic joint. So here is a low placement of a pelvic binder, and as fate would have it, of course, I have a small pelvis here and a large pelvic binder. So the low placement has been proven to be much more efficient than placement up high. And you can see that if we place the support, we compress the pubic joint. If the compression is applied right here, both pubic joint and sacroiliac joint are compressed. Whereas if you have a high placement, you can see that it tends to compress the upper sacroiliac joint, but it may in fact perpetuate hypermobility at the lower SI and lower pubic joint. So again, low placement is the preferred method. So that's a brief summary of what we're going to cover now. There are exceptions to that which we will discuss. So pubic joint dysfunction is defined as widening of the pubic joint of up to 10 millimeters. And it may be associated with pain and some impact on activities of daily living. Whereas pubic symphyseal diastasis occurs secondary to a severe fall, a motor vehicle accident, or a traumatic birth causing rupture with separation of the pubic joint greater than 10 millimeters. And a very recent published case, the person presented with 8 centimeters of separation, and of course that required surgical stabilization. And it, with varying degrees of symphyseal diastasis, it greatly impairs basic functions such as walking, rolling in bed, and pain is severe. Now in the recent past, a 25 millimeter separation was the cutoff. Lesser amounts would be treated conservatively with a pelvic binder, bed rest, use of a walker, frambulation, etc. Whereas 25 millimeters or greater was treated with surgical stabilization at the pubic joint. But there's a couple of cases in which separation was greater, and I can think of a case of 47 millimeter separation that was treated conservatively and treated successfully. So there is a gray area there between the non-surgical and the surgical management, but certainly an extreme case such as 8 centimeters, without a doubt, that's a gross and severe instability of not only the pubic joint but of the sacroiliac joint as well. Again, in the acute phase, a pelvic binder worn low is what is done. That is a standard of care to where to apply the support low at the level of trochanters and pubic joint. Now, a key concept is that there is a minor population who may present to an outpatient clinic that has a small symphyseal diastasis or pubic dysfunction, and use of a pelvic binder can be very helpful in that population. There is some very good research that demonstrates there is 40% greater compression at both the pubic joint and at the sacroiliac joints when the support is worn down low. For ambulatory clients who do not have acute trauma, a pelvic support can be helpful in allowing restoration of joint stability and can be worn for 6 to 12 weeks. Even if worn a few hours a day, it may be helpful, and of course can be worn longer than that. Each case is individual. I do suggest periods where the belt is off to minimize skin breakdown, and also to allow the person to have daily feedback in experiencing how it feels when the belt is on and how it feels when it is off. If not worn too tight, the belt can be worn at nighttime, and I suggest always wearing it over underclothing. And I want to talk about a couple of myths. One myth is that the support will slip up when sitting, and it might depend on the type of support or how firm it is applied. And I do favor wide supports, especially ones that are form-fitting to the shape of the pelvis. And I would suggest it's not necessarily true that it does not necessarily slip up, and I suggest the person try it. Another myth is that it creates weakness. And if a person requires a support because of pain and because of laxity, then a reduction in pain by wearing the support is going to cause them to be more active. And that certainly counters that. And if they're more active, then they're going to do more strengthening activities throughout the day. And so that is another myth. And we don't foster using it, the rest of their life. We encourage using it for a period of 6 to 12 months to build up stability by keeping those ligaments in a shortened position, by keeping the joint in a shortened position, and improving proprioceptive feedback, etc. So use of a support can be very helpful, and one can even do strength testing with the support off and with the support applied to see how that affects muscle function. And there's a gray area with some clients. You're not sure if they need a support or not, and my advice is to simply try it. I had one client and I couldn't tell. There was nothing in her presentation that caused me to believe that she needed a sacroiliac support, except that after being very successful, working very hard on exercise and progressing those over several weeks, she was still very symptomatic, even though she did not outwardly show that. And on the day that I was to write a progress note, she broke down and cried and said, "When am I going to be able to be more functional and interact with my kids? I used to be very active with them, etc., etc." And reevaluated her, and there was nothing that caused me to suspect hypermobility. So I just arbitrarily applied a support, and it was immediately very helpful. So when in doubt, try it. It takes just a few minutes, and there is a population out there that benefits significantly from having a support. There's a lot of marketing out in the community for sacroiliac supports, which are worn higher up. And again, there is much better compression when worn low. However, there are different types, different categories of sacroiliac joints, and there certainly are patients who benefit from wearing a support high and a population that benefits from wearing low. What I recommend is that we try placement at both low and high placement to find out what this single individual needs, rather than letting the literature completely guide us. If you read the sacroiliac literature, then you'll find that sacroiliac supports are very positive in a large part of the population, but the population with pubic involvement, where the pubic joint hypermobility is primary, that population responds much better to low placement. And again, due to variation in anatomy, they don't all follow the rules, and therefore I think we should try placement low and placement high and see what that individual requires. And I hope this will be helpful to you in managing this underserved population. and I thank you very much.